Okay, so we're going to go ahead. The following patient has been referred for an upper endoscopic ultrasound with a possible FNA. He's a 64-year-old male who presents with a 1-month history of fatigue, nausea, and painless jaundice. He has a medical history of being a non-insulin dependent diabetic requiring insulin. He does have hypertension being treated with losartan, and he does deny any history of drug abuse, alcohol abuse, or previous blood transfusions or recent international travel. His physical exam shows that he's afebrile. He does have scleral icterus and has had some weight loss and does appear lethargic. Some diagnostics have been done. He does have elevated liver enzymes, and his CT shows that he has a query adenocarcinoma within the pancreatic head. So I think one of the most important things to know is why we're doing the EUS. First of all, you may not get this information from when the patient is scheduling, depending on how your patients are scheduled. So you may have to find it out from the patient's history or from the endoscopist himself. But first of all, it lets you know what type of EUS scope you're going to be using. For this case study, we know that the patient's been scheduled for an FNA, so we know we'll be using the linear EUS scope. But if your site's anything like ours, we have a limited amount of EUS scopes. So you may have to change your scheduling around to make sure that you have the right scope available at the right time. It also gives you time to prepare for any therapeutic or tissue acquisition that might occur during the procedure. So you can give cytology a heads up if they normally attend, or it gives you time to get everything you're going to need to prepare for this procedure. It also lets you know if your patient's adequately prepared. Having the patient prepared may prevent a complication or any delays from occurring. So like any other endoscopic procedure, you want to ensure that your patient has an IV for procedural sedation and the patient's been NPO. But because we're going to be doing an FNA, we also want to make sure that the patient's coagulation is within normal limits. We want to know, is the patient on any anticoagulants or any antiplatelets? If they are, have they been stopped? And is their INR within normal limits? Patients having therapeutics or a tissue acquisition really should have blood work drawn on the day of the procedure. And if that's not possible, it should be drawn as close as possible. In this case, we know that an FNA is going to be performed, but we need to take it one step further. We need to know if it's going to be a solid lesion or a cystic lesion that's going to be aspirated. If it's a cystic lesion, then we know we have to give prophylactic antibiotics. And again, knowing why we're going to be doing the EUS will allow us time to get the antibiotics ordered and administered before the procedure. And lastly, give some consideration to whether or not anesthesia should be involved at your site. In this case, we're going to be using the linear EUS scope, which has a large 12.8 millimeter outer diameter to accommodate the 3.8 millimeter working channel. So it also requires a blind intubation, and it has a long rigid tip. Some patients just have trouble tolerating the large diameter scope. And what you have for procedural sedation, such as fentanyl and midazolam, may not be adequate to sedate the patient. And also, because you're going to be performing an FNA, we want to ensure the patient's not moving during the procedure. Obtaining an adequate specimen is dependent on the endoscopist being able to locate and access the suspect area. So it's imperative that we have the patient sedated properly. So I guess the main nursing consideration for the procedure, main nursing considerations for the procedure consist of the setup and the post-care of the endoscope, monitoring the patient, and assisting with therapeutic and tissue retrieval and documentation. The setup of the EUS endoscope is a little bit different than a regular endoscope because a balloon is applied at the distal end. And when applying the balloon, we need to ensure that the channels have been cleared of air and to ensure there's no air in the balloon when the endoscopist fills the balloon with water. As Rachid had mentioned, air can add artifact to an already complex EUS image. The patient information should be added into the EUS processor to ensure the images can be identified. And as for the patient setup and monitoring is very similar to other endoscopic procedures. Your procedural sedation policy should be followed. At our site, we monitor the patient's heart rate and O2 saturation constantly and their blood pressure every 5 minutes. But if it's anticipated that a procedure may be lengthy because a therapeutic or tissue acquisition is going to be performed, consider using end-tidal CO2 if it's available at your site. Some procedural sedation policies also require that the patient's sedation level be monitored during using the Ramsay scale throughout the procedure. It just ensures that the patient stays in their intended level of sedation and that the patient doesn't become over-sedated. One of the most important roles of the nurse is the specimen retrieval after it's acquired by the endoscopist. So after all, an accurate diagnosis is dependent not only on the acquisition, but also the retrieval of the specimen. Assisting with an FNA or a fine needle aspiration or an FNB, a fine needle biopsy, is very similar. And the main difference is the type of needle that will be used. So needles come in 3 main sizes, a 19 gauge, 22 gauge, and 25 gauge. And they're either non-coring or coring. A non-coring needle is usually used for an FNA, whereas an FNB, a coring needle, will be used. Our physicians tend to use a 22 gauge FNB needle for both an FNA and an FNB. So it's really up to the endoscopist to what needle they'll be using. And usually it depends on the type of tissue that they are sampling to obtain the diagnosis. During an FNA, cell fragments and blood cells are aspirated and the morphology of the cells are examined for diagnosis. Whereas in an FNB, the goal is to obtain a core tissue sample and the architecture of the tissue is examined for diagnosis. The type of medium that the specimen is placed in will also differ between an FNA and an FNB. For an FNA, usually the specimen is the medium is cytolite, because cytolite lyses the red blood cells and preserves the specimen. You may also be asked to put the specimen in transport media, such as an RPMI, if they're thinking there's a possibility of lymphoma. The RPMI just ensures the cells remain viable till they can be examined. Following the FNA, the specimens are reconciled and sent to the cytology department. For an FNB, the sample is placed directly in formalin, as formalin fixes the tissue and does not allow it to degrade. And then following an FNB, the specimen is reconciled and sent to the histology department. I'm just going to review a few steps involved in tissue acquisition retrieval, and there's multiple steps, so I hope I don't kind of lose you along the way. When the physician is ready to obtain the specimen, the biopsy cap is removed from the working channel of the scope and the needle is inserted down the working channel. Most EUS needles have 2 settings. We're just doing the biopsy right now as on the video. But most EUS needles have 2 settings, one to adjust how far the sheath comes out the distal end of the scope, and the other adjusts how far the needle comes out the sheath. Prior to handling the needle to the endoscopist, ensure that the settings are correct and the screws are locked, so there's no movement when inserting the needle down the scope. The setting to determine how far the needle should come out the sheath should be set at 0, and the length the sheath comes out of the scope will differ depending on the scope and needle being used. Prior to obtaining the specimen, the endoscopist should ensure the sheath comes out past the transducer. If this is not done, then when the needle is deployed, it could penetrate the distal end of the scope, causing a costly repair to the EUS scope. The endoscopist will pull back the stylet from the distal tip and insert the needle into the target tissue. The stylet is pushed forward and then removed from the needle. The stylet is going to be used later on, so keep it in a clean, safe place and preferably not under the patient's pillow. The needle is inserted to the target tissue. Several times at this point, the endoscopist may ask for suction, and this is done by attaching a syringe to the proximal end of the needle handle. The use of suction is really dependent on the endoscopist's preference and the type of tissue being sampled. Once the endoscopist feels an adequate sample has been obtained, the needle is brought back into the sheath and locked. And the needle is unscrewed from the scope, withdrawn from the working channel, and handed to the nurse for the specimen retrieval. Some sites have a cytology tech present during the procedure, and if so, the first step would be to make a slide. If they are not present, then this step is omitted. But the purpose of the cytology tech being present is to improve the diagnostic yield and to give feedback to the endoscopist about the quality and the adequacy of their specimen. To retrieve the specimen, the needle is advanced out of the sheath slightly and the stylet is reinserted to the needle. Inserting the stylet will cause the sample to be expelled from the distal end of the needle and a small drop is placed on the slide. If inserting the stylet does not expel enough of the specimen, air can be injected through the needle. Injecting saline in the needle at this point is not advised as it would dilute the specimen. After a slide is made, the remainder of the specimen is expelled into the medium. After the sample is expelled using a stylet, there will be some remaining sample in the lumen of the needle. And the stylet is removed and the needle is flushed with a combination of air and saline into the medium to make a cell block in the lab. When retrieving the sample, it's very important that the tip of the needle does not touch the slide or the media, as the needle should remain sterile because several passes may need to be made. The stylet's reinserted into the needle and the endoscope will continue to make passes until enough diagnostic material has been obtained. Following the procedure, endoscope is going to be, a pre-clean will be done on the endoscope as any other scope tape being taken to the reprocessing area. And following the procedure, we want to make sure that we want to document where the specimen was from, how many passes were completed, and where the specimen was sent, either to cytology or histology. Vital signs, Ramsay sedation scale, and any other untoward events that occurred during the procedure should be documented. And before taking the patient to the recovery area, the patient should be assessed to ensure that they are stable for transfer. A scoring system such as the Eldred score can be used to assess if the patient is ready for transfer. So just some post-procedure considerations. Once the patient has been moved back to the recovery area, they should be monitored for any complications. Although complications are rare, they can include post-sedation respiratory depression, and this is evidenced by decreased respirations, a low oxygen saturation, and a decreased level of consciousness. Consider oversedation and the need for reversal. For this reason, a reversal kit should be readily available. Does the patient have abdominal pain and is their abdomen soft? It could just be excess of air or CO2 used during a procedure, but also could be indicative of a perforation or pancreatitis, especially if there's a therapeutic or an FNE has been performed during the procedure. This may not be seen initially, but may present later on, and the patient may return after discharge. And although rare, if an FNA or an FNB or a therapeutic has been performed during the procedure, there is a risk of bleeding. Interluminal bleeding is usually identified during the procedure, whereas extraluminal bleeding may not be present till later on. Signs to watch for would be trachycardia and hypotension. Bacteremia is also rare, although it may occur post-FNA and FNB. The patient can develop increased temperature and rigors. This risk increases post-aspiration of cystic lesions, therefore the need for prophylactic antibiotics when sampling cystic lesions. There should also be a standard to ensure the patients are ready for discharge or transfer after the procedure. At our site, we use a modified PAD score to discharge patients and an Eldred score to transfer patients. Once a patient meets the discharge or transfer criteria, they can be discharged from the unit. And finally, patients should receive a written copy of their discharge instructions. It should include diet instructions, when to resume driving after sedation, signs and symptoms of possible complications, and what to do if they occur, and any follow-up appointments.
Okay, thanks, Jen. So that was a wonderful explanation of what becomes routine to Jen and I, but we forget that it is quite an undertaking and quite a process to do these procedures. My unit, we have a select number of nurses who are specialized in doing endoscopic ultrasound, yet they are always training their colleagues and exposing their colleagues to this procedure. Endoscopic ultrasound is one of those endoscopic procedures that will just continue to increase. And so a couple of key takeaways before we open it up to questions. You know, endoscopic ultrasound is common, and if it's not done at your center already, stay tuned, because it's one that many people are training in. It has widespread applicability, and it's something that will continue to evolve and expand in the future. It really requires a good understanding of the anatomy. I love my EUS days. I sit with my nurses and we talk about what we see in the structures, and it really just becomes an educational day for all of us involved when we do these procedures. And endoscopic ultrasound intervention, the FNA and beyond, you know, we don't just biopsy cancers anymore. We treat gastric varices, we drain pancreatic cysts, we put stents into bile ducts using endoscopic ultrasound. So these are complex procedures, and it really requires, you know, the cooperation of skilled endoscopists and skilled endoscopy nurses to do these procedures. And so the close working together of these parties really ensures that we're going to be successful for our patients. And with that, MC, I'll pass it back to you.
Perfect. Okay, thank you so much. That was fantastic. I'd like to open the floor now for questions.
Rachid, just wondering how many EUSs do you do that would prevent an ERCP approximately?
Yeah, that's a good question.
We're doing more.
Yeah, we could do more for sure. You know, every time you get a negative ERCP, you can probably, for stone disease, you could probably ask yourself, could I have done an endoscopic ultrasound? You know, we probably do in the hundreds of endoscopic ultrasounds at our ERCP site here in Calgary, but we still do negative ERCPs. In a perfect world, of course, you would do endoscopic ultrasound on everybody, but as Jen alluded to, you have an allotment of scopes and time, and so every endoscopic ultrasound you do will take a little bit more of both of those. So what we really try to do is define the criteria of people who are what we call moderate probability. So, you know, if you're high probability for a stone, you should have an ERCP. If you're low probability, you probably shouldn't even be in our unit. And if you're moderate probability, so maybe your liver enzymes were up, but they've improved. Maybe you had pain overnight, but you're now pain-free, or you're less jaundiced than you were yesterday. Those are the indications for doing this endoscopic ultrasound step in between the ERCP.
So our next question reads, what is the frequency of pancreatitis following FNB?
Low, very low. You know, the literature will say probably 0.5 to 1%, but I think it's much lower than that. It largely depends where your needle goes. So if you're biopsying a cyst, your chances of pancreatitis are negligible. If you're biopsying the pancreas, so not a pancreatic cancer, but if you're biopsying the pancreas for autoimmune pancreatitis, or to define chronic pancreatitis for some reason, and you're putting a needle across pancreatic parenchyma, there's a chance you're going to hit the duct or a meaningful side branch of the duct, and that's where you're going to trigger pancreatitis. So I've had a few occasions in my career of pancreatitis from a needle biopsy, but it is rather uncommon.
It says, hi Jennifer, thank you for the presentation. To what extent do you include the patient's family members or caregivers in the discharge education process?
Unfortunately, we do not. I think the only time that we really do is if the patient is unable to understand the instructions on their own. Otherwise, it basically is just with the patient themselves. And that's why we want to make sure that they have the written discharge instructions, because often they don't remember. But not always do we include the family members.
And Jennifer, I'll ask my own question. Has that changed because of COVID, or is has this kind of just been a trend throughout your time with the GI unit?
I think it's just a trend throughout. It's just because we put it through a lot of people in the day, and to have family members up for every patient that we have, it has definitely gotten worse for COVID, because we don't even want visitors in the hospital anymore. But it definitely all along, just because of the volume that we have, we just can't manage that many family members and talking to every family, so we tend to just talk to the patient.
Perfect, thank you. Rachid, how often are patients getting antibiotics prior to FNA or FNB procedures?
Jen touched upon this too. So when you're biopsying solid things, you typically don't need to give antibiotics. So, and most of what we biopsy is solid. So we're biopsying solid tumors, cysts, things like that don't require antibiotics. But if you do put a needle into a cyst, although the literature is not compelling or terribly strong, we administer an intravenous dose of antibiotics during the procedure. I'm sure Jen does the same. And then we give a prescription for a few days of oral antibiotics thereafter. I've, touch wood, never seen an infection from a cyst aspiration, thankfully, from EUS.
Rachid, I'm wondering if you could go back to the linear video and just kind of walk us through a little bit of the anatomy as you're going through, and just that F&B portion. We saw Jen explaining it so well, but just if you could just point it out to everybody, that'd be great.
Yeah, I played this so Jen can sort of talk about what we see here, but what you're seeing is a hypoechoic structure, which I'll show you here in just a moment, which is the pancreatic tumor. So we're sitting in the duodenum, and this is the view of the pancreatic head we get. And this round structure right here is a pancreatic cancer. This black structure I keep going to is actually the common bile duct. So the common bile duct should taper nicely through there, but you can see it basically abruptly stops at this tumor. And for those who do ERCP, this is where we would see our stricture, right? This is the stricture that we commonly see. This is the area that we brush the inside of the bile duct. But you can see why EUS is so much better than brushing, is that you're able to actually sample the solid tissue rather than relying on the inside of the bile duct. So we're in the duodenum, you get the common bile duct here. This actually allows us to do common bile duct interventions now, our ability to see the common bile duct that well. But you find the tumor here, and if I just jump ahead a little bit, what you're going to see in a moment, sort of at this little top right corner, that little white structure that comes out is the sheath of our needle. And as Jen said, that has to be outside of the scope, or else you're going to puncture your scope and damage it. But once you see that sheath, it aligns where your needle tract is going to go. We've already done this, but we've checked to make sure there's no major blood vessels in this area. And then we puncture the tumor. And now, our nurse is usually applying some negative traction with the stylet, or applying some suction, or taking it out entirely. And we're just passing our needle back and forth through the tumor, fanning across different sections of the tumor, and retrieving cells into the needle.
Awesome, thank you. The next question says, what therapeutics are done for varices in EUS?
Yeah, so that's a little bit of a newer one, although I think I've been doing it now for 4 or 5 years anyways, is that, so gastric varices, which are always challenging to diagnose and treat, and they're scary for a lot of endoscopy teams, is EUS allows us, just because of intimate relationship against the gastric wall, we can see gastric varices, and we can see the feeding vessels that form into these big gastric varices. And so what I'm able to do is, under EUS guidance, is put a needle right into the gastric varix, and either do what we do endoscopically, which is apply glue, or more novel is to actually put a coil, so a radiopaque coil that will either clot the varix itself, or create a scaffold for the glue to stick to. And so that is a technique we use a lot for large isolated gastric varices. It's very nice. You don't see any blood because it's all black and white. So if you're poking into a varix and things are going wrong, you're not the wiser for it, and you treat the varix in that manner. So